Just admitting everyone in.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everyone, and welcome once again to CATHIP's Health Hour. Welcome to all our regular listeners and really welcoming all those that are spending time with us for the first time. I'm Dr. Vanessa Apea, and I'm your host for today. So just a bit before we go into what's happening today, just wanted to give you a bit of background about who we are and what we're doing. So CATHIP is the Caribbean African Targeted Health Improvement Program, and it really is a collaborative, it's educative, and it's empowering health literacy so that knowledge and understanding reaches people where they are to enable them to take control of their health and to support others. And it's made up of a fantastic partnership, which includes CAHN, the Caribbean and African Health Network, the Black Health Initiative, the Royal Assembly Redeemed Christian Church of God, RAFA International Development Agency, Croydon BME Forum, and the Enfield Caribbean Association. And all these associations and groups have come together to make sure that ourselves within Black communities have access to the information that we need. Every time I host, I always say that we are really honored by all the guests that we have, and today is no exception. And it's a topic that, you know, it is focused on Black women, but as we know, Black women are the center of our communities, and so it's for the partners of Black women, it's for the family, friends, all of us within our networks, really focusing on Black women's perinatal mental health and well-being. And I think that, again, within the Health Hour, we tackle topics that we don't always feel comfortable talking about within our communities. If we've been through it ourselves or had difficult times, we may not have had the space to talk to anyone about it. So I'm really excited that we have Dr. Olanike Bika, who has a special interest in biopsychosocial and perinatal mental health. And Dr. Bika is a consultant obstetrician and gynecologist and also clinical director at the Rotherham Foundation Trust Hospital. So over to you, Dr. Bika, and thank you so much for being here today.
Thank you, Vanessa. Good morning, everyone. Thank you for joining me this morning. I'm just going to share my screen and then we can start. Okay. So this morning, over the next 40 minutes or so, I'm going to talk to you about Black women's perinatal mental health and well-being.
Dr. Bika, sorry to interrupt. You're not at full screen yet, just to say.
I'm going to bring that up now. There we
Beautiful.
go.
Thank you so much.
All right, so today we'll be focusing on Black women's perinatal mental health and well-being. And I hope it's a safe, open space for everyone that's here. I hope we're able to take something away from here. And I hope you've got the opportunity to ask quite pertinent questions at the end of the presentation. So the perinatal period starts from when you're pregnant till about a year after pregnancy, and comes with it many different physical and now mental disorders. So this is not new. So perinatal mental health disorders during pregnancy and the postnatal period can have quite significant consequences for moms, the society, and the family. From the recent Embrace report released this year, we know that Black women are 4 times more likely to die in the perinatal period compared to white women. In general, women are 3 times more likely to die by suicide in the perinatal period as well. So 1.5 women, 1 to 5 women per 100,000 may sound like a very small number, but once we lose a woman, it has significant implications in our society. So I'm going to share with you a case, and I'll apologize in advance if this causes any distress to anyone, but I'll keep it as relatable as possible. So I cared for a 27-year-old lady. I saw her a year or so after her baby. It was her first pregnancy, pretty healthy, slim, young Black lady. There was a history of depression when she was in university, but nothing significant. She was under midwifery-led care, so she didn't really have to see any doctor at all in pregnancy. Quite an uneventful, straightforward pregnancy. In labor, there were some concerns. She needed her baby monitored when she was in labor. They did find out the baby's heart rate was dropping, so she needed an emergency cesarean section, which in retrospect was quite traumatic for her. Her immediate postnatal period while she was in hospital, the usual post-major surgery recovery, there were no concerns picked up, there were no concerns raised. She was discharged home by the 2nd day. She was followed up by her community midwife at home. Things were okay, and the usual checks: how's your mood, how's your wound, how's everything going? She was discharged to her health visitor. The first time her health visitor saw her, there were no concerns at all. Things were pretty okay. Maybe not sleeping as well, which is what you would expect most new moms to talk about. I think over the subsequent days after that visit, her husband noticed, slight bizarre behaviors, not really sleeping well, not eating well. So invited his mother in to come and support both of them. And remember, this is the first baby they have. So moms really picked up a lot of things, quite bizarre behaviors, hearing things, seeing things, not sleeping at all, not really eating well, not caring for herself or her baby. So these are alarm bells. They've called for the health visitor to come back. She's noticed that there's a significant difference in this lady from the first time she met her to this current episode. She's gotten in touch with the GP. The GP has asked them to pick up a letter and attend accident and emergency. Unfortunately, at this time, extremely busy in accident and emergency, took quite a lot of time for them to be seen. This is a new mom that's acutely unwell. And remember, this is mental, this is not physical, so probably not something that they can see. She was seen by the crisis team, which is the adult emergencies team at the time. And they noticed that she was quite unwell and needed admission into a mother and baby unit. Mother and baby units look after women in the perinatal period. So when they're pregnant or after they've had the baby, with the aim of looking after acutely mentally unwell women and their babies. And the nearest site to us is either Leeds or Nottingham. When A&E is busy, it means there's hardly ever any ambulance services. So at this time, they were waiting for hours for an ambulance service for transfer. Dad was getting quite agitated. Mom was becoming quite unwell. Mother-in-law had gone back home. Eventually, Dad decided to take Mom all the way to Leeds by himself. This is in the middle of the night. He's got a woman that he's having to control the windows so she doesn't jump out of a car. He's got a screaming baby in the back of the seat. 2 years afterwards, I can tell you, Mom's got no recollection of what's happened. She is better. She's no longer on medication. She's with her baby. Dad's got anxiety. He's got post-traumatic stress disorder. He's a little bit better. He's no longer on medication. As a family unit, they're better. I think learning from this case for us would be communication. And I know the midwives that work in my unit, they're very passionate about women, regardless of race or background. We did not know this woman was around. The difference that would have made would be we would have admitted her to our either labor ward or our ward, would have maintained her dignity. We would have given her and her husband a safe space. We would have looked after that baby until the ambulance service arrived. There was a lot of learning for the staff at A&E. You don't allow dads to take acutely unwell women in the middle of the night to another hospital. But that's how desperate Dad was. But I'm glad to say that they're okay. We have learned from this, and this will be applied to other women as well. So for Black women, you know, we've got these stereotypes, whether it's said out loud or not. We're sometimes described as the angry Black woman, sometimes poor, uneducated. We're stereotyped as having children because we're wanting to take advantage of public finances or accommodation. We're seen more negatively when it comes to things about sexual activity, sexual risks, motherhood status, and socioeconomic status. Black women are seen as being overweight because we don't really fit in. We're built different. We're overconfident, over-assertive, promiscuous, not feminine enough, and aggressive. And we know these stereotypes do have an impact on us. And on the other side of this, Black women, we're invincible, or it comes across as if we're invincible. People don't listen to us. We feel as if we're unheard. There's a stigma and negative perception around Black women. And we're also aware of these unique stereotypes around us. When it comes to healthcare professionals, either consciously or subconsciously, sometimes these stereotypes are there, and so the attitudes can lead to discrimination and eventually health disparities. There was an inquiry by the charity Birthrights and found that Black, brown, and mixed ethnicity women do feel unsafe. They're unable to really raise their concerns because sometimes they're ignored or dismissed. An example they did give was pain relief. So you can imagine a woman in labor certainly will be in pain. What has pain got to do with race? This is something that I have also come across personally. So the implications of this, when you then add pregnancy to the mix of this, we all change when we're pregnant, our physical appearance, the way we think, the roles and responsibilities we have to take on, especially based on our backgrounds as well. Our perceptions will change and our social relationships will change as well. And then in that mix, you've got the stereotypes in the background, the discrimination and racism that also play an important part in the background. And rightfully so, there's evidence to say from the last maternal mortality report released this year that there's racial disparity when it comes to moms dying. And as I said earlier, 4 times more than the white woman. This will have an impact on perinatal mental health, either directly or indirectly. So the Embrace report is a confidential inquiry into why mothers die. And it has stated that there's a significant increase in the rate of suicide in the perinatal period. And this is an increase from the last report. These reports are retrospective, which means that we've gone through the pandemic. We also know that globally there's a significant increase in the mental health crisis. And I wonder what that report, the next report, is going to show. I know that these numbers might seem small. However, when you lose a woman, you lose a generation. It has an impact on extended families, her family, and the society as a whole. The common theme among the women that died in this report is that they've gone through many adversary, mostly complex social problems. And so most women dying through suicide, substance misuse, homicide, or accident. 3/4 of women who died from substance misuse also lost their child, mostly through child.
Sorry, Dr. Nike, we've just lost your sound, so I'm just double checking. There we are. If you could, I think if you could unmute, I think for some reason you've muted.
Is that better? Can everybody?
Perfect.
I think there was a noise in the background as well.
Thank you so much.
Can everybody hear me now?
Yeah.
Yes, we can. Thank you.
So of particular, they've also noticed an increase in the number of suicides in our teenage moms, an increase in documented domestic abuse in this report, and evidence that the impact of social services can have on women with complex social problems, including mental health. So the way women have died in this report when it comes to mental health is been described as quite aggressive in the way men might commit suicide, with hanging being the largest, one of the largest numbers. You've got overdose, falling from height, accidents, as well as train accidents. Pregnancy, I must say, is not a protective factor. These disorders are not caused by women. They're not self-induced. It can happen to anybody. And so the word woman, put yourself together should not exist when it comes to mental health and pregnancy, because there isn't anything she can do about it. It's not a headache that you can ask her to take a paracetamol and feel better. So there's so many different types of mental health illnesses. I can't possibly go through all of them, but I'll go through some of the common ones. And most of us have gone through baby blues. It's quite common, quite mild, and self-limiting. So within about 2 weeks or so of after having your baby, it should have subsided. Depression can start the minute you're pregnant. Some women come into pregnancy with the illness of depression. It can start anytime during pregnancy or in the postnatal period. So most women or most people are aware of postnatal depression. And the other extreme of that is when you have postnatal psychosis. So it means it's become so bad and so worse, they become acutely unwell. The same thing applies to anxiety disorder. Same thing applies to panic disorders, and all of these can become worse in pregnancy. Social anxiety, I've also noticed in the last couple of years, has become worse since the pandemic. And so you can imagine having to care after a woman who can't get out of the house or who has problems mixing with other women when they're in the waiting area. Women that are at extremely high risk are the ones that are already diagnosed to have bipolar disorder, schizophrenia, or have had a history of psychosis in the past. And so it's important to start talking because there's help out there. There are people that would listen as well. So the risk factors that I have come across most of the time in women that have really become unwell, there's been no risk factors at all. They've been pretty healthy throughout their lives. The only thing they've done is they've gotten pregnant, and all of these emotions, feelings, and mental health illnesses have then become a new. It's quite difficult for them to understand, quite difficult for them to prescribe, and because of the stigma around it, very difficult for them to have a chat about. Some of our women have gone through childhood or adult trauma. Some of them have a background history of mental health illness. So with that history, it's easy to then work with them because they're able to recognize when they then deteriorate and are able to talk about it, as long as a safe space is created for women to be able to do this. Some women will self-harm for the first time in pregnancy. And so having to see a woman in clinic, or even if you're at home, is just being observant about things. So if I were to see a woman in clinic and I would notice what she wears, why is she wearing a very long sleeve or a jacket in the middle of summer, for example, I would ask those questions. If it's someone that I know has self-harmed before, sometimes I do ask to see her arms. If there's nothing, however, it doesn't go with how she looks or how her perception and behavior is in clinic, I might ask to look at other parts of her body or have her have that chat with me about it. They will open up when they do feel safe. It might not be with me, it might be with people at home that they can give consent to come to clinic and then talk to a health professional about this. Domestic abuse remains a risk. This was much higher during the pandemic as well. And so there are women out there that are still going through things, even through pregnancy and raising children. Some of our women have gone through child sex exploitation and difficult childhood pregnancies and many, many more things. So I hope that the message goes out there that yes, these are the risk factors that can be associated with mental health illness, and women have the confidence to be able to talk about this in a non-judgmental, open and safe space. It's important to note that when a woman loses a child, it also has an effect on her and the family, but more importantly, the woman. It doesn't matter whether it's a miscarriage, a termination of pregnancy, a stillbirth, a neonatal death, or whether the child's been taken into care. To them, it is still a child, and that matters. Birth trauma is something that's come up a lot more, I'll probably say, in the last 5 years. And to me, it's not because it's a new thing, it's because women are now starting to talk about it. And it's important that we as Black women also have the confidence to be able to talk about birth trauma. It's a form of post-traumatic stress disorder. It can happen throughout pregnancy, it can happen during your delivery, it can happen afterwards as well. And there's support out there when this happens. It's a type of post-traumatic stress disorder, and that's because expectations are different, triggers are different, and women's experiences are different. A difficult long labor may mean something else for a different woman. A painful delivery or the mode of delivery may be different. Women's expectations when you look at the birth plans might be very different as well. An unplanned emergency cesarean section may have an impact on the woman the way it's happened. And so it's important that when women get pregnant, you know, they prepare the birth plan, they have an idea of what they want. But it's important to be open, it's important to be practical, it's important to go through these with people or health professionals early so that you can have your plan A, you can have your plan B, you can have your plan C. Nothing becomes a surprise to you. You're taught how to be able to communicate, how to be able to say yes or no, how to be able to take or withdraw your consent. And that's self-help as well, to be able to say, can you give me 2 minutes so that I can process what's happening? Can you give me 2 minutes? Because there's just too many people in the room. You're frightening us right now. Can I have just one person come in? Talk me through what's going on. If it's an emergency cesarean section, I'm happy to go about it. And the way health professionals, we can be quite monotonous in the way we work. And so sometimes we forget that there are people that actually are not used to this, and it can be such a significant trigger to them. Other shocking, unexpected traumatic experiences like bleeding or the baby becoming a bit stuck, or even an assisted instrumental delivery can result in birth trauma. The way they've recovered afterwards as well, the way they've been treated, the way they've been left alone or managed can also result in trauma. And it's important that we start talking about these things. I definitely have to talk about child sex exploitation. It's not something we talk about often in our community, but it does happen. In the UK, we have 1 in 20 children haven't had a history of being sexually abused, and they do pass through our health services. Girls are definitely more affected than boys, and they are usually abused by people that they know. And the people that abuse them are usually not too far from their age. So we always think it's an older person, much older person, or an old uncle or an old grandpa. But sometimes it's teenagers in the 17, 18 age group as well. So it's just things that we need to be mindful of. So as a result of conflict, sometimes neglect and emotional deficits, then it's easier to exploit these children, manipulate them with affection, attention, and rewards in exchange for gifts and sexual favors. And so when they become pregnant, they then worry about them losing the pregnancy because they feel that they may be damaged. They worry about the loss of control over their body during pregnancy, concerns about whether their unborn child is a boy or a girl, depending on who's abused them as well. Certain situations may remind them of the trauma, especially during delivery, being unable to remember details of what's happened, feeling emotionally numb or cut off from the feelings. Examinations might be something extremely daunting for them, and concerns about mode of delivery, which ideally all of these things should be addressed in pregnancy. During delivery as well, birthing is most likely the time when you then start to notice that there's a problem or there's symptoms that they're experiencing. It can cause them extreme distress, flashbacks, and dissociation. The fear of examination, for example, during an induction of labor, might be when you then pick these symptoms out. It's the point whereby you have that conversation, listening to the woman. She's got a right to be able, to want to express herself and change her mind if she wants to. These women sometimes are concerned that a caregiver might notice they've been damaged, even if there are no scars. Being touched without consent is something that they've gone through before. Being exposed to strangers is something they've gone through before. And this is what you may end up going through in the delivery room as well. Feeling confined to a bed and concerned that the birth of the baby may bring up things that they've probably locked up for a very long time. In the postnatal period, they may find it very difficult to bond with the baby. They're overly concerned about the safety of the baby now and in the future. They might not want to breastfeed. It might be a choice, but it might also be because it reminds them of an abuse they've gone through before. It can then bring up mental health concerns. They may experience insomnia, which is very significant when it comes to perinatal mental health. They become easily irritable, upset, or angry, extremely alert, hypervigilance, especially when it comes to the babies, finding it difficult to do everyday tasks. Other triggers we might take for granted. It might be something as simple as morning sickness. You have women carrying cups around, they're spitting all over the place, vomiting, they're in and out of hospital. They find out that they're carrying twins or triplets with the high risk that comes with it. Not everybody's lucky to have that emotional or physical support at home. Some people have mixed feelings about having a baby. Some people are healthy before they become pregnant. Before you know it, they're diabetic or they're hypertensive in pregnancy, or the placenta is not in the right place. There's so many things that may happen in pregnancy that may then become a trigger, more of anxiety, a lot of worry, of depression. Concerns about their babies. For example, if a baby is diagnosed as having a cleft palate, that automatically starts to bring up something that's never existed before. Concerns about substance misuse, medication. with perinatal mental health, we noticed that a lot of women would have stopped medication before they even see a professional. This all has implications. It's creating an opportunity to have that discussion with the woman. Sleep is also a really, really big trigger. You can imagine when we don't sleep and we're not pregnant, pick up time, you can't straight, you really can't do much. If you add pregnancy to that and perinatal mental health, it's a toxic mixture. Major life events that women have looked after that have lost their mothers, the women have looked after that their sisters are diagnosed with breast cancer, for example. Things do happen, life does continue. For women, fear of the unknown. What's going to happen to me when I'm pregnant, when I have my baby, after I have my baby? Some women have babies when they're 24 weeks, extremely early. That comes with its own stressors. And as I've earlier explained, traumatic delivery as well. So what can we do as a society? Look out for ourselves, look out for women, create a safe space. Create an area whereby women are able to talk. If you pick up symptoms, they're happy to talk about it with you. You will notice they may be extremely tired, yet they're unable to sleep. They don't show any interest in things that usually creates pleasure for them. Low self-worth. They tend to withdraw from loved ones, not really interested in looking after their babies. And then you've got the guilt that comes with that as well, or the shame that sometimes they may feel with that as well. They've got thoughts about hurting themselves or their baby. They may feel detached from friends and family. They may have persistent physical problems, but these are psychosomatic problems. They are not really physical. They may suffer with mood swings. They may feel quite anxious and irritable, and changes in eating, in sleeping, no energy, unable to concentrate. These are little things that we may be able to pick and start a conversation with women. But it's so important to recognize red flags. When you do recognize red flags, you need to report it. They need to be able to report it. So please encourage them to do that. New thoughts of violent self-harm. Sometimes they will not disclose it. Sometimes it's something that you need to be able to ask directly. Self-harm in different forms. We all think it's just cutting. Sometimes it's burning themselves. Sometimes it's head banging. Sometimes it's severe scratching. Sometimes there are things that they do not want to talk about because of the stigma and the shame that comes with it. But close ones, close friends, close husbands, partners, mothers, please ask these questions. Sudden onset or rapidly worsening mental health symptoms. You're the best person to be able to pick that up because you've known them longer than we have. Have that discussion with them. And a lot of times, these women do not know. They have not got the ability to recognize that they're going through this. For partners, husbands, families, they're aware. And so you may then need to be the one to be able to bring this up with a health professional because it may be a sign of an emergency. Persistent feeling of estrangement from babies. I've seen a woman come in, she's got red nail polish on. It's very unusual. This is not something women have time for when they've just had a baby. And then you have to look at several things to say, hang on a second, how come you've got time to polish your nails, but you're not really sleeping, you're not really looking after your baby? Or it's like the traffic light system. If I look at my nails, it looks red. It means it stops me from harming my baby. So they're just subtle things that you must be able to pick up to be able to raise. Concerns in the perinatal period. So when women get pregnant, especially those that have had a background of mental health illness, they're concerned that they might deteriorate in their symptoms or relapse. So the things I've written up here are things they need to discuss with a health professional, because these are the things that can only reassure women. How to balance the risks and benefits to her and to her baby, how to keep her safe. Will my baby be harmed? The importance of being compliant to treatment. If I stop my treatment abruptly, what can happen? You know, what are the risks of treatment to me, to my baby? Am I able to breastfeed if it's something that they want to? And every woman should have a right and a choice to have their own personalized care plan. Prompt treatment and what to recognize if they become unwell. The risk of overdose is important so that we recognize how much do they have at home, how much do I need to prescribe. Starting at the lowest dose possible, explaining that to her, the need to increase it and explaining that to her, because if you don't work with the woman, if the woman is not at the center of care, then it's very difficult to have the woman on your side. She must be in control of her care, and we're there to support. And that's also an important message to take out there. Social services, it's all over the news. We've lost a few children online. We've also had, if you remember the Colombo case, Black children that have been subjected to horrific care. And so safeguarding and child safeguarding especially is quite heightened. However, mental health is not a reason for child safeguarding in pregnancy or afterwards. But it is important that they make sure that women are safe, women are healthy, and they're able to look after their kids. And the ones that I've been involved in, that I know safeguarding have had to be involved in, are women that then use substances and are quite unwell, not enough to look after themselves. They haven't got the right support, family support to look after them or support them or their babies. Safeguarding generally means protecting women's health, well-being, and human rights. So perinatal mental health in itself is not a reason to have child safeguarding. It's important to get that there. It's important to be able to work with them earlier rather than waiting till the end, because that causes a lot of stress. It causes a lot of anxiety as well. And so it's important that women remain safe, they remain well physically and mentally. They get the support that they need earlier rather than later on in the perinatal period, so that they've got a really good pregnancy experience, a really good pregnancy journey to be able to care for themselves and their baby. There's also a cultural stigma of the fear of the child being removed. And so as a result, women may not necessarily want to talk about their mental health or disclose any symptoms, which in itself is a significant risk. So creating that environment at home is important for them to be able to talk about these things and get help on time. This also means that women can have the best experiences that they can have for themselves and their babies. The babies are with the right people to care for them, which is their mothers and their families, and you keep the family unit together. So various treatments are out there. There's nothing as good as self-care. Talking to your friends, talking to your family, putting yourself first, having the confidence to discuss how you feel, you know, making time to enjoy things that make you happy is very important. Sleep as much as you can. It's an understatement. Some people can't, but sometimes you have to learn to stop and switch off, and then start again. Regular exercise, healthy diet. There's therapy out there as well. If you get in touch with your midwife, your health visitor, or your GP, they should be able to direct you to the right place. And it's important to know that within 2 weeks, you should have had your first assessment, and within a month, you should have had your first intervention. And that's part of the NICE guidelines. So please be aware that that's your right as well. I can't go through all this medication. Women are on very different things. It's important that you have time to talk about your medication. We do not advise stopping medication. We want women to be safe. We want women to be healthy. We want them to have a good pregnancy experience and journey all through. Okay. Safest things we use in pregnancy, usually the SSRIs, sertraline, fluoxetine, citalopram. But every woman's different. Every woman's mental health experience is very different. Taking time to go through the risks, the benefits, the impact on her baby is so important. We do not stop people from breastfeeding. We do not force people to be on medication. If they have an understanding, if you're able to work with women, if women have a right to come with their questions, they should get the care and the advice when it comes to their medication as well. It's important to know that medication lists bottom, carbamazepine, lithium, valproate, especially in women of reproductive age group. I would advise that they're on contraception, because these can be quite significant in that they can cause fetal abnormalities. However, these are membrane stabilizers, and so if there's a history of bipolar affective disorder or schizophrenia, they will stabilize your mood. In pregnancy, it can always be switched to something different. And so we do offer pre-pregnancy counseling. And so if you're expecting or you're trying to get pregnant, I would advise contraception so that you can plan this in advance. You can meet with a health professional, decide on your medication before you start. All antidepressants carry a risk of withdrawal symptoms. Women's perceptions are very different. Families' perceptions are very different. They think of the fellow in the town center withdrawing from drugs. It's very, very different in neonates. Most neonates, we don't see anything. When I started this almost 12 years ago, women used to be in hospital for 48 hours because they're on very low dose antidepressants. We fought for this in our hospital. It's now 12 hours or less. The ones that may show withdrawal symptoms are usually women on substances as well, or multi-therapy as well. And even then, usually they stay in hospital for 24 to 48 hours. So it's important that you're aware of that as well. There are lots of processes in place for women. Obstetrics is changing. It is patient-centered. It is woman-centered. It means that the care you get should be centered around you. And for it to be centered around you, you need to know that you've got a voice. You need to know that you're well-researched. You need to come with your questions, because there are processes in place to ensure that you're safe and your journey is smooth as well. You need to feel confident enough to ask. So GPs ideally should let us know if there are any concerns at all. Women are entitled to continuity of care in general, and especially mental health care. So I, for example, in my hospital run a mental health antenatal clinic. I've got 2 vulnerability midwives that work with me, and we coordinate care. So it's important that they're kind of seeing the same person and information is disseminated to the perinatal mental health team, to our therapists, either in the community or in the hospital, to the community midwives, to the psychiatrist, to the GP, but more importantly, to the woman. So if that happens, then it creates a space for the woman to feel safe and to be able to be part of her care as well. Plans for this woman, they want to know what's going to happen now, what's going to happen in the short term, what's going to happen in the long term, what are the concerns that I need to be aware of. And these are things women should know and can ask when they see their health professionals, especially if there's a family history in mothers, in grandmothers, perinatal mental health. It means there's a possibility that it can happen in daughters as well. And we don't tend to talk about these things. It's time to talk about it. It's time to start breaking down the stigma around mental health. As I said earlier, new expressions of violent self-harm are red flags. Please, there are different ways of self-harm. You have to know the person to create that space for that person to be able to tell you, so that if there are any changes, you're able to pick that up as well. We will involve a psychiatrist if we need to, if it's urgent. If you need admission, it will be to a mother and baby unit. And I don't tend to do face-to-face. I don't tend to do telephone consultation. I prefer face-to-face consultation, so I know who the person is. It's an opportunity to hold hands. It's an opportunity to look at her and tell her she will be okay. And so if your consultation is telephone, I feel you've got a right to say, actually, I would rather see this person than it be a telephone consultation. I think that human contact sometimes makes a difference. An early postnatal review of medication by your GP is important. So if, for example, you've come off your medication throughout pregnancy and you've been okay, once the hormones start to settle, it means there's a risk that your symptoms can come back. And so the earlier you're able to sit down with your GP and restart your medication, the safer you will be. So support systems that are in place in my hospital, and I'm hoping it's the same in other hospitals, but they may be called different names, is vulnerability midwives. You've got your birth trauma midwives, and they both work with different therapies, therapists in different fields. Your bereavement midwives as well. We do have mental health antenatal clinics and work closely with the perinatal mental health team and some mother and baby units. We work closely with the addiction services, the community therapist team. We've got a hospital mental health liaison team. The crisis team, although they're used to adult psychiatry, are starting to have training in perinatal psychiatry because they're completely different entities. Psychiatrists are now starting to specialize more in perinatal psychiatry because it's very different to adult psychiatry. It tells you the significant impact of pregnancy on mental health. And so we're having a lot more. In the last 5 years, we've had a lot more money being injected into perinatal mental health. So I'm hoping, and I know these things do take time, that we can only get better. And as a community, we need to be part of this as well. Early help is usually via social services. Most people do not know about that, especially for our teenagers. Help with finances, help with accommodation, help with single accommodation for very young moms and their babies. It's all there. And so the earlier we're able to start this journey with them, the easier. Leaving things till last minute is never a good idea. And we're not a community in isolation. We've got friends, we've got partners, we've got families. You know, let's all work together as a unit, as a community, to make sure our women are safe. So what I would advise is be involved in your care. Obstetrics is changing. It's now patient-centered care. What do you want? How is this going to be an interesting journey for you? How do I support you? Gone are the days of, I'm the consultant, I'm the best, I know best. No, you go and do your research. You come with questions. You come to clinic, you come and challenge us. Let's sit down, let's have a chat. Let's find out how this journey is going to be okay for you. If you're not getting on with that person, you've got a right to ask for a second opinion. Can I speak to someone else? Because this is you, this is your body, this is your baby. You need to be aware of that. You can have a second opinion. Preconception counseling, as I said earlier, so your pregnancy can be planned even before you get pregnant. Feel free to disclose concerns, create your own safe space. There are certain things you can say in clinic, certain things you can request while you're in clinic. You know, is it possible for it to just be myself? I'm sorry, I don't want to see a registrar, I'd rather see you. There are certain things that have happened at home that I feel I need to discuss with you. It's my duty to be able to create a safe space for you. Communicate. Most of the women I see in clinic, when they first start, they've been trafficked all the way from Africa. They've gone through the most horrendous things ever. It's just ensuring that you're fine, you're in good hands. Let me show you how things work. Let me show you what you're entitled to. Let me show you what you can become. A mother, you know, a partner. Let me show you that you can be safe. It's that education that can happen from home. Not everybody has that support. It's creating that space to be able to say, actually, this is what's happening, this is what I can do when I am in labor. It's putting plans in place for them. You can ask for this. If you don't want this, no, she's fine, let her have her other one. It's fighting for what our rights are as a community, regardless of where you are. Being aware of red flags and reporting them when it comes to mental health is very important. I've talked about patient-centered care, knowing what your choices are. Birth planning, we all have all this Hollywood fairy tale births planned. And I know that that's what I would want women to experience, but sometimes it doesn't happen that way. It's been quite practical, it's forthcoming, it's explaining to women what may or may not happen, plan A, plan B. How do you manage in an emergency? What do you ask? What are your rights when you're in labor, for example? How do I make this safe for me, for my baby, for my partner? Even if I have, an emergency section and I bleed and there's so many, concerns, you can still make that journey your journey. Communication is important. Listening, speaking, being heard. You have to be able to do that. Managing your expectations can also make a difference to that. Therapy, if you need it, please, I'd advise that you take it. It's always better, they say, if it's someone that you're either from the same racial background because they have an idea of what you may be talking about, what your experiences may be in comparison to if it were a different race. They are out there, you just have to ask. Being compliant with your medication, being compliant with your management plan, as long as you're part of that, as long as you've given consent for that, as long as you're aware of what you can and should do. Sleep, 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 easier said than done. It's a fast, fast world, but sometimes you have to just slow down and switch off. Be active, healthy diet and rest. And I hope that, all our women have excellent experiences. They know what their rights are. It's listening, it's speaking, it is asking. Thank you. Any questions?
Dr. Bika, thank you so much for that presentation. I think that was just fantastic. And so many things are going through my mind, and as you were speaking, and I'm sure there are many people on here that so many things that you've said are relatable within themselves and recognized it in their family and friends. And so really just thanking you for your sensitivity as you have discussed it. And as Dr. Bika said, we appreciate that some of these reflections, discussions could be triggering, and we are here to support you. And I know that my colleagues will be putting support resources in the chat as well. So thank you all so much for listening. And now is the opportunity to ask questions and for us to share perhaps experiences, but any questions that you want to ask directly from Dr. Bika. She's here for us. So please do put some questions in the chat, or feel free to raise your hand and then I'll come to you. Dr. Bika, can I ask you, would you be able to stop sharing? Is that all right?
Yes.
Yeah, and then we can just have a wider view of people that may want to ask some questions. And some people have contacted me directly within the chat. And I think one of the things that someone in the chat has just said, that it was wonderful to see the processes that are in place at the moment. And I think perhaps again to highlight with you, but I think that is so important because we hear so much. Someone says, am I breaking? Can you all hear me? Okay, great. We hear so much of the the poor experiences that many women have experienced before us, unfortunately. So then if we do become pregnant, the fear then of entering care and the expectation of what's going to happen, what kind of care are we going to receive, that anxiety can be really, really traumatic for many women. So someone in the chat to me was just saying, thank you for highlighting the positive steps that have been put in place to ensure that women have a better birth experience, but also have a better support after birth, which I think is crucial.
Yes, it is. Thank you.
So one of the questions that has come into the chat is, someone has said that, for example, you may notice from someone signs of depression and anxiety, and it's a young person in their 20s, but they're refusing to engage or discuss or talk about it. How can you help someone in this situation?
Okay. I work with 2 vulnerability midwives. We've got a really good understanding. If a young woman is not wanting to engage, we will engage with you, which means it's not unusual for me to say, is it okay if I give you a visit? We're not in the hospital setting, and I'm going to come with Nicola. I don't mind sitting on your floor, having a chat with you, making you comfortable. You need to be able to go out of your comfort zone to be able to draw that person closer. And we know that young parents right now don't want to have anything to do with healthcare. But if you're really concerned and you want to make sure that person is safe, you're going to have to go out of your comfort zone. And it is something that we're used to doing.
Great, thank you so much. And someone else has highlighted, they had to go, but they said, thank you for highlighting the male point of view. And someone sent me a message in the chat that she unfortunately had a very difficult time in the perinatal period, and she feels much better and life is moving forward, but her husband sadly is still really struggling from seeing her in that way. What support is out there for the men, she says, and how can she help her husband?
I think I'll start off by giving an example of a husband that was really struggling. And I found myself in a situation whereby I am looking after this woman. I have got this husband that I know is quite unwell. I get in touch with perinatal mental health. They're telling me that they haven't been allocated finance to look after dads. And so what we've ended up doing is speaking to one of my colleagues, Alison, please, I have got a dad that's really, really struggling. I need help. I need somebody to look after this man. It just takes one person to care enough to want to do that. But I can say now that perinatal mental health have now got a forum for dads. I can say now that more and more dads are speaking out. And so there are Facebook groups, there are groups in communities just for dads that have gone through traumatic births as well. All you have to do is ask. So your health visitor, sometimes there's information in your GP surgeries of where you can get this support. So he shouldn't struggle on his own. Yeah.
Thank you so much. I think that's really reassuring, really reassuring for people to know that there are more targeted services for partners. And I'd like to, I'm getting another question in my private chat, and I just want to thank people because I know some of this is very personal, so people don't want to put it in the open chat but are sending it privately. But we really appreciate you engaging, asking us these questions and sharing your experiences or reflections. So just want to really thank you for your engagement. And it would be great to know for those of you, everyone listening, you know, where are you in the country? Are you watching by yourself, or are you in a group watching this? Just to have a sense of who's with us. So it would be great if you could just put in the chat where you're listening from. But someone has sent me a message that I can very much relate to. I'm always very honest that I had a very long journey to a successful pregnancy. And I had a successful delivery, but the care that I received postnatally was very traumatic. And you know, me I was a consultant then, very well established, and still had a really difficult time, and has only until very recently have gone back to the hospital. You know, my daughter is 7. And I've only just gone back to feedback what happened to me. But someone had just commented that the guilt that they felt, just reading the question, the guilt that they felt of experiencing perinatal difficulties after having a baby, after trying for so many years. And I wonder, Dr. Bika, if you could just comment on that.
I think, as with many women, you know, I'm so happy that women themselves are speaking against the culture, the behavior, what women have gone through for so many years and haven't talked about. Women are talking about that now. And that's why there's so many reports that have been coming out in the last few years. And what are the common themes? Communication, listening, you know, not respecting boundaries. Women are complaining about the behaviors of midwives, of care support workers, of doctors, report after report after report. And what work has gone into maternity in the last few years, it's not things like instrumental deliveries or better ways of doing a cesarean section. It is behaviors, managing behaviors. It is patient-centered care. Gone are those years of, I know best and I'm busy and this is what I'm doing. No, 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 no. Times have changed and you need to know that. It's not acceptable anymore. It's now patient-centered care. Before COVID, I mean, unfortunately, everything's now been blamed on COVID. Partners in my hospital were staying with women overnight, wherever they were. Unfortunately, that had to change with COVID, and we're starting to open that up just to offer support, because I know that there's staffing concerns when it comes to nurses and midwives as well. So partners and families can also feel involved, but times have changed. And it's not the big things, it's the little things that make a difference to women. It's the listening, it's the support. You know, you've got breastfeeding support nurses. Now you've got them in theatre, you've got them in recovery, you've got them in labour rooms, you've got them on postnatal ward, you've got volunteers that are coming in to help. So there are things in place. There's still a lot of work that's going on, but a lot is on behaviours, it's on support.
Thank you so much. And another question has said that, as you've also stated, pregnant Black women are often known not to be listened to by certain health professionals. And you've answered a bit of it, but are there advocates that women can be approached or accompany them to hospitals? So if they are concerned about it at home, is there anyone that they can contact to engage?
Yes, and the community midwife should be able to give you details of how you can have that support. And I've also mentioned you can always have a second opinion. If you're not getting on with that community midwife or that doctor, if you're just not really marrying when it comes to whatever plans or whatever concerns you have, you change that person. You have a right to be able to do that without fear of discrimination. You should be able to say, can I get a second opinion? Actually, I don't like this midwife. Can I have another midwife? I've got somebody else coming to support me, or I need somebody to support me. Can you give me that information? They should give you that information.
Thank you so much. And just another question was that, again, everyone is reinforcing what a great presentation, so thank you so much. But someone has said that you've talked about the services that are available to mums through the perinatal period. However, our communities tend not to come forward because of fear and the risks of their babies being taken away if they disclose mental health issues. And so how culturally and racially sensitive are the services, and what is put in place to ensure professionals understand the cultural stigma? That's a great question. Thank you.
So I think everyone now, as mandatory, we all have to go through courses that address this. And this is just everyone in the hospital. And when you look at maternity services as well, we have to recognize that BAME is important. It's not something that people used to talk about. It's people talk about now. We all have to go through that training. Midwives and doctors have to go through that. And we've got advocates as well that champion BAMEs when it comes to maternity. And you should ask about that in your hospitals as well.
Great, thank you. And another reason that I love hosting a health hour, you meet everyone, so many different people that are doing the work that's needed in the community. And so Bianca in the chat, thank you, has said that also, you know, part of her role is supporting young mothers and offering listening and guidance and accompanying them to the hospital as well. So thank you for your work, Bianca. Oh, Bianca, you're very welcome to speak. I can see you've put your hand up. Thank you.
Thank you, ladies. This is so important that we're having this conversation. Thank you for the space. Just going back to what you were saying, Vanessa, that yes, a lot of women, we're finding more and more women more focusing on like being scared about their babies being taken or just how they're going to be dealt with in regards of disclosing mental health issues rather than their pregnancy, which is quite shocking because when you have a baby, that is the light and joy of your life. And imagine you're going, you know, all of these months and, you know, you're trying to enjoy your pregnancy, but you're just, you know, you're always on edge. You're not really being able to enjoy your pregnancy because in the back of your mind, subconsciously it's just there, whether you think actually I do need to be seen, I do need to see a doctor, but is my baby going to be taken from me? Unfortunately, what's happened in the past is healthcare professionals have took action first and then asked questions later. We're seeing this a lot in social services where there's no real conversation. Baby's just taken first and then we'll ask later. So it's just a vicious cycle because if you're then just constantly worried that, you know, if I disclose I've got mental health challenges, is my baby going to be taken? Maybe at the start of your pregnancy, those kind of thoughts was quite subtle, but then by the time you get to 8 months, now you've probably got yourself in the worst position. Maybe now baby's at harm whilst you're pregnant, because we know that stress is a direct link to, you know, ill health. And now you're actually in a bigger problem than you was when you started out in your pregnancy. And then one might say, well, why didn't you come to us? Why didn't you say something? And then it's this conversation we're having now because mum is absolutely petrified. A lot of the women I work with, for the life of them, they will not come forward. Unfortunately, yeah, they just won't, because they are absolutely petrified. And it just echoes, because it just makes me think, if you times 1 or 2 women by the whole of England, that's a lot of women when on the grand scale of things who are at home suffering in silence. They may have 1 or 2 people to talk to, but the point is that service should be there and they should be wanting to go, but they won't. So thank you so much.
No, Bianca, you know, thank you so much for sharing your experiences and reflections. And I'll let Dr. Bika kind of add and comment. But what you've just been saying, as you were talking, others were writing in messages to me, just agreeing with you and saying, you know, they knew someone that had suicidal thoughts and was scared to speak out. Thankfully, that person is better, but it was hard. And so I'm just really grateful, as you started off saying, that we're having this space to reflect on this and really encourage people in our lives, in our communities, that there are people like Dr. Bika there that are there for you, to support you. So I'll just hand you over to Dr. Bika.
I think it's important that we're talking about this today. And I think, and I'm hoping that we're able to pass out messages to women out there. Perinatal mental health is real. It also means that it is time to remove the stigma and to start talking about this early. We recognize that when things are left too late and you're really, really ill, there's a risk to yourself, there's a risk to your baby. So talk about these things early. Get support early. Get help early. When everything then gets accumulated towards the end, that's when you result in getting that risk. And sometimes even when your baby is removed, it's working towards getting better, getting your baby back together. I do appreciate that not everybody has got that family support behind them, which also tends to make a difference. So that baby then stays with family. But I'm hoping, following the discussion we've had here, that we're also able to spread this out to women in our society to say, look, there is help out there. Talk about this early. Get help early. Don't leave it until you're so unwell that you can't do anything about it. There is help out there.
Thank you so much. And just another reflection just of someone on the call that when you said about empowering yourself, and if you're concerned about something, you know, challenge, ask your doctor. Someone has commented that they asked for a second opinion during their delivery and to save her baby, and she said that, you know, always ask if you don't feel comfortable, you know, ask for clarification. If you know, it may not be that you need a second opinion, you just want clarification and to understand the plan. So again, thank you so much for sharing your experience there. Another question is that just asking, is there value in making cultural competency training mandated for primary care? Because this is where women often access care once they've had their baby.
I would say so, definitely. I would say so. And we've got to try and push for that as a community to be able to get that care. I think primary care is becoming more and more difficult, especially with the decline in the number of GPs. However, we still owe it to ourselves. We have to do things ourselves. We have to push things ourselves to get it out there. And so if we're wanting it to be mandatory, then we have a lot of work to do to be able to do that. And that's being heard. And that's making sure that we're being heard.
Great, thank you. And then I'm just going to do one more question, because I am very, very aware that we're ticking off with time. But it was about, I think it's a really important question related to being able to breastfeed if you are given medication. And the person has said that when they had difficulties and they were asked to take medication, the reason that they didn't take it is because they were worried about breastfeeding, and no one explained that. And it wasn't until the second pregnancy and things were difficult again that this was explained, but has asked, could you reinforce this message?
Yes, breastfeeding, we don't stop anybody. We never stop anybody. It's important to discuss risks and benefits. It's important to ensure that the choice is the woman's choice. It's not the clinician's choice. A lot of medication, whether you're thinking of paracetamol or brufen or wherever, you have little bits in breast milk. Some antidepressants will be in breast milk, so we will use the ones that you've got the list in breast milk. You've got minute amounts in breast milk. However, the women that are on antipsychotics, and we know there are in breast milk, if this woman tells me I want to breastfeed, she's aware of the risk that you may have some of this in breast milk, which means that when you eventually stop breastfeeding, you need to keep an eye on this baby. There's an attachment that comes with breastfeeding. There's a satisfaction that comes with breastfeeding. So keeping mom and baby together, the bonding that comes with breastfeeding, the journey they've gone through, what they're wanting, we will not stop women. Our role is to be able to support them through what they want. However, it's educating them enough for them to make that decision.
Thank you so much. And I was just going to end, but there's been a flurry of questions, but I'm just there's one in the chat, Dr. Bika, if you'd give us this chance, because I think this is something that when we talk about patient empowerment and feeling confident to speak up, you know, this is a a natural concern is, if you do ask for a second opinion, what if it's declined? What can you do in that situation? So in terms of advocating for yourself. So I wonder if you've got any comments on that. And then that really will be the final question before I hand over to Sandy and colleagues.
If you ask for a second opinion, you walk straight to the hospital main reception. You find out from the receptionist how you can make a complaint, where can you make a complaint, you make that complaint. If you're short of time and you think, you know what, I need answers today, ask for your head of midwifery. Go straight there and say, I've asked for a second opinion. I am concerned I'm not being listened to. I need to speak to somebody today. I'm telling you, you go straight to the top. You go straight to the top. Simple.
I love that. And I have to say, actually, that is the perfect way to end, just going straight to the top and advocating for yourself. Dr. Bika, I just want to thank you. Huge thanks for giving us this fantastic presentation. I want to thank everyone that has listened today and engaged. We don't take it lightly. I always say it, but it's a Saturday morning when many of us are so busy, running around trying to live life and get on top of life. And then we take time to listen to the healthcare professionals and gain this knowledge. So thank you so much for your time. And thank you again also to all the CATHIP contributors that make this possible. I'm going to hand over to Sandy now to give us some announcements, but I just wanted to highlight to everyone, these are triggering conversations. They're empowering, but can also trigger you in experiences that you've had before or experiences that you are going through now. And I know that colleagues from CAHN have put details of where you can get support within the chat, and we will paste that again now just so that's reinforced. But again, thank you so much. Thank you again, Dr. Bika, and I'm handing you over to Sandy.
Thank you very much. Sorry, thank you very much, Dr. Vanessa Apea. Thank you very much, Dr. Bika. It was a really good and interesting session. So, in terms of the announcement, colleagues, I don't know if we have a slide on the screen, or should I just use my slide here?
Yes, I'm sharing it. Give me 1 second, please.
All right. I hope everybody enjoyed the session. It was a pleasure having you, Dr. Bika, and we hope to have you soon. So our next health hour session will be on the 27th of May, every Saturday, as you know, and we will have the honor to have Ms. Karen Joash, and she'll be talking about menopause. So please do share with friends and family, really, and register. You can register at the event. You can register via emails at events@cahn.org.uk, or feel free to catch up on any session via YouTube or Facebook as well. Thank you. Next slide, please. Okay, we also have a Healthy Heart session every Tuesday. So the next one will be on the 23rd of May from 6 p.m. to 7:30 p.m., where we have Dr. Hiba, who is a registered nutritionist, and Dr. Alice answering your questions. We also have a physical session with Orlando, my colleague. So again, please register and share with anybody who you feel may necessarily not go to the gym. Thank you. Okay, and we have our bereavement peer support group. It's so next sessions, as you can see here, we have our next session on the 15th of June. Next session will be the 15th of June. It's online from 7 p.m. to 9 p.m. If you know of anyone who is going through any difficult time really due to bereavement, please do refer them to us, and they can contact Roslyn at roslyn@cahn.org.uk. Thank you. All right. So we have a home office session today. This session usually happens once in 2 months. So the next one is today at 1 p.m. So if you can, please join us. The topic will be on work visa. So at these sessions, we have officers from the home office to engage with the community. So please do, you can call us or send an email to advocacy@cahn.org.uk for more information. Okay, and for so our big event coming up next week, it's Africa Day. For the first time, CAHN is organizing an Africa Day. It's going to be at Salford University on the 26th of May from 2 p.m. to 6 p.m. Loads of activities. We have some civic leaders attending and community leaders. Please, again, do share this information, and we are waiting for you. Again, for any information, you can contact Sandra on 07389710957, or again, email events@cahn.org.uk. Okay, and again, for any of these flyers, if you need more information, please contact my colleague Sandra at sandra@cahn.org.uk. Okay, and just to mention, CATHIP is, we have some partners we're working with as part of this program. So a massive thank you to Enfield Caribbean Association. For any information on this organization, please contact Dion John at dion.john@theeca.org.uk. Next, please. And yeah, we also have RAFA based in Birmingham, so RAFA International Development Agency. Again, for any information, please contact admin@rafa.org.uk. And a massive thanks to our partners. Next slide, please. We also have the Royal Assembly Redeemed Christian Church of God. Again, you can contact Dr. Samuel Okarenta on the telephone number 07882 931539. Okay, and another partner in London is the Croydon BME Forum. For more information, please email them on info@bmeforum.org. Okay, Black Health Initiative, again, you can contact them at admin@bhilead.org.uk. Just to say a massive thanks to our partners across the UK, who, thanks to them, we're having more people to join. So my name was Sandy Kuju, Head of Community Empowerment and Advocacy, and it is a pleasure to have you all here. If there are any other topics you want us to discuss as part of the Health Hour, please do send us an email. And it was a pleasure having you. Thank you very much, Dr. Vanessa, and thank you very much, Dr. Bika. Okay, have a good weekend, everybody. Goodbye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our Health Hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.